Okay. All right, so we start. Now I need to relax now. So this is probably the most interesting for the young and old topic out there, because most of you are young, so you probably don't have any sexual dysfunction issues. And hopefully you won't as you get older. I'm 60, so obviously it's a little different for the older folks. But I wish somebody had told me all this information when I was your age, because it could have saved me a lot of trouble. Although back then we didn't know as much as we do now. So today we're going to cover not only the sexual dysfunction data on men, but also on women. Women, we're going to leave it for the second half. We're going to try to do this within an hour and a half max. I only have 76 slides, which is not that many compared to what we've done before. So bear with me. All the questions at the end, we're recording this online and also in here. And we're going to start first with the waiver and the disclaimer that I always have. This is not medical information that is intended to change anybody's clinical care, or you guys are not clinicians. You basically support staff that needs to know basics on the science behind sexual medicine. Because at Empower Sexual Medicine, the products are probably one of the main top sellers. So it's just a basic understanding of why these products are used, how they're used. This is a basic review because it will take hours. There are conferences that take a whole week to cover this topic, okay? So just to go through real quickly, because we're gonna get into details later, but they're compounded products that Empower and other pharmacies produce. And these are products that are only available through compounding. They're not available through a brand name commercial option. So that's a good thing. Part of me always asks me why the pharmaceutical industry hasn't gone for patenting any of this, but it is what it is, and actually it's a good thing for the compounding industry. So we have the penile injections, which we'll discuss later. We have the PDE5 inhibitors, and we have some other oral products and oxytocin, which we may or may not cover later on. We'll get into details on the new orally disintegrating tablets, ODTs. They are very convenient, lower price, so I think it's gonna give Empower an edge in the market. I've already tried two, so I can say pretty good. Tastes very great, actually better than the Troches. So I'm very excited. We'll go through details later on that. I just wanna go through the products. We're covering all the penile injection products for men, obviously. I covered in the last lecture, a long lecture we had on a month ago, 2-hour lecture, all the testosterone products and HCG. And so we're not gonna cover that today, because obviously that will take 2 more hours. But basically testosterone increases libido and erectile function in some men, but in both men and women. So that's why I just wanted to mention it again, not only the injections, but the creams and the pellets that are coming up too. So the basics on erectile dysfunction. Erectile dysfunction is defined as the inability to achieve or maintain an erection sufficient for satisfactory sexual performance. So somebody can have a temporary ED or permanent ED issue, depending on the conditions. It increases with age, cardiovascular disease, diabetes, high lipids, cholesterol, all that. Diabetes is the most common cause. Over 60% of diabetic men have this problem. People that smoke, people that don't exercise, and obesity also have a higher risk. And it's also strongly correlated with depressive symptoms. And the US pharmaceutical industry for treatment of erectile dysfunction is worth over $6 billion. And that was 2015 data, so it's probably a lot more now. The prevalence of erectile dysfunction, it's very hard to get good data on this. There've only been 2 or 3 cohorts that reviewed mostly older men with different health conditions. So this incidence may or may not be 100% right, but the Massachusetts male aging study was one of these cohorts that actually looked at the incidence of erectile dysfunction among different age groups. And obviously, as people got older, men got older, they had more ED. And you see in those two grays and one white are the degrees of erectile dysfunction. The lighter grays, minimal, the darker grays, moderate, and the white area is complete ED. I mean, men that basically cannot get an erection even with stimulation and all that. And that really impacts not only relationships, but self-esteem, quality of life. And ED really has been associated. There are actually studies that show that men with ED tend to have more risks for cardiovascular disease, heart attacks, all kinds of comorbidities. So ED per se is not only something that, obviously we need to to expand our species, but also the fact that ED has been linked to higher risk of mortality. Over 322 million men will have ED by the year 2025 by the estimates of this study. So what are the causes? And everybody here, we're a sexually active group here because you're younger. And there's psychological aspects of having an erection or even being stimulated. When men or women, that's probably number one. A lot of men I deal with, I talk to on Excel Mail, we have over 30,000 men chatting every day. There are over 200,000 posts. They tend not to want to look at that. They want a pill, they want a solution, but they do not want to deal with any aspects of the intimacy issues or psychological issues, insecurities, etc. That's something that most men do not want to deal with or talk about. So it's one of those very difficult things to address with doctors. Hormonal, obviously we know low testosterone, low thyroid, high prolactin can affect erectile function and libido. Vascular, meaning blood flow related issues. The penis basically needs blood flow to keep an erection. And some men that have issues with vascular issues, either diabetes or cardiovascular, may have more of a issue with ED. And neurologic, that's nerve related. Men with pelvis related surgeries or injuries, lower back injuries that affect nerves that go into the penile tissue could have more problems too with ED. There are organic causes, like I said, different disease, cardiovascular disease, diabetes, surgery of the colon, bladder, pelvis, and prostate. Men with prostate cancer surgery or chemo or radiation, most of them have erectile dysfunction. And that's one of the most severe side effects or problems related to that surgery. Neurological causes, like I said, lumbar discs, MS, etc., hormonal deficiencies and illness. The risk factors, treated heart disease, even if you have heart disease and you're treating with anti-lipid agents or blood pressure medications, you still have a 39% risk factor. Diabetes, even if it's treated, you still have 28%. And as I said, treated blood pressure also. Especially blood pressure medications have been associated with ED. And that's one of the biggest problems we're having as we get older, that most of us have to take either a blood pressure med or a statin for lipids or other medications that may actually influence or get in the way of an erection. As I said, diabetes is common, and this is one of the biggest problems out there when it comes to erectile dysfunction. There's psychogenic or psychological issues, anxiety, depression, obviously fatigue. Something else that men on my side have a problem admitting that they're not sleeping enough or they're having a lot of stress. So they're always expected to perform. Obviously, their partners are, their wives are also tired too. So that fatigue is definitely a big issue when it comes to not only sex drive. So we're talking about two different things always, and we tend to combine them when we say sexual dysfunction. Sexual dysfunction could be related to low sex drive and also erectile dysfunction. So some men, especially when they get on testosterone, may have a better sex drive, but they're still having ED. Or some younger men may have good erections, but they have sex drive issues. So when we talk about sexual dysfunction, we're not only talking about one thing, okay? We're talking about different, and the same thing with women when it comes to drive, guilt, stress, problems in the relationship, obviously, excessive alcohol use, use of street drugs. And how do we know, especially for men that are having problems with erectile dysfunction, whether or not it's psychological or organic, meaning, illness related? When it's psychogenic, it could happen all of a sudden. It could be situational, depending on what situation you're in, what kind of sex partner you have, whether or not you're stimulated or turned on. But if you have nighttime, like normal waking or nighttime erections, especially at the end of the sleep cycle, then you probably don't have organic ED. There's a psychogenic issue there, because that really is a main indicator of healthy erectile function. When a man has an erection either through dreaming, or men complain sometimes, or not complain, then they go to the bathroom to pee around 4 or 5, and they may have an erection, then that's actually healthy. And that's a good indicator that organically, physically, there's not a problem, even if they cannot get an erection when they're trying to have sex with their partners. That's more of a situational or psychogenic related issue. Fear, depression, anxiety, and performance anxiety is a huge issue. Once it happens once or twice, and I hear that from all the guys online, the self-confidence starts dropping, and it's like a vicious circle, like a snowball effect, where you may not have an organic problem, but the fact that you failed to perform once or twice, especially if you were judged or criticized by your sex partner, which is the worst thing anybody can do, can affect your confidence and create psychogenic issues. When it's organic, it could start happening gradually, all situations. Usually you don't have morning time erections or nighttime erections, and there is no erections on masturbation. So the first one, on the psychogenic one, you may not perform with a sex partner, but you, at the time of masturbation, you have a good erection. So that also tells you it may be something related to intimacy or to anxiety issues related to the. So that's how you separate. Okay, do I really have a problem that is physical or is all? And people hate to be told that it is in their heads, because obviously nobody wants to admit that. But there are many issues like ED that are related to the psychogenic aspects of it. So as I said, this is just a summary: depression, obesity, stress. What are the causes? Smoking, lack of exercise, alcohol abuse, diabetes, heart disease, high blood pressure, neurological diseases, vascular disease, high cholesterol, and relationship problems. Medications, blood pressure meds, beta blockers, even calcium channel blockers, diuretics, antidepressants are well known for that. Actually, one of the main barriers for depression treatment for men and women is lack of a lower sex drive, erectile dysfunction. And there's another sexual dysfunction that I haven't really mentioned, is the orgasmic dysfunction for men and women, that you may be able to have an erection or have sex, but you never reach orgasm. That's a sexual dysfunction. And that could also be affected by medications. Antidepressants are well known for that. So some people stop their meds because of this. And obviously some people really need to take their depression medication. A lifestyle, like I said, psychological disorders, blah, 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 and your hormones, chronic illness, etc. And this is just a review. You can even see the font. Even antihistamines, like diabetes drugs, lipid lowering agents, beta blockers, recreational drugs, like I said before, but even antacids can affect ED and libido. So the physiological mechanisms of erections. The stimulation of a penile shaft by a nervous system leads to a secretion of nitric oxide. And you're going to hear some about nitric oxide later on. It's basically a molecule that activates a lot of processes in our bodies. But nitric oxide causes a creation of what we call cyclic guanosine monophosphate, which functions to relax blood vessels, vasodilation, they open up. So erectile tissues in the corpus cavernosa can fill with blood and subsequently cause a penile erection. So basically, nitric oxide stimulates this cGMP, which opens up the capillaries and the blood vessels in the penis for blood to come in, and then basically it gets locked in from this actually valve in the base of the penis. So these PDE5 inhibitors, which are including obviously Viagra, Cialis, vardenafil, and Stentra, inhibit an enzyme called PDE5, which is present in the penis that functions to destroy this GMP. This GMP enzyme that actually opens up the blood vessels, there's a PDE5 enzyme that tries to block it, tries to break it. So pharmaceutical industry came up with ways to inhibit that enzyme so that GMP is free to do its job, okay? So that's how it happened. And Viagra was really discovered as an ED drug by accident. So we'll talk a little bit about that too. When it comes to like desire, libido, there are all kinds of factors involved too. So, and this is something that also we deal with online with all the guys discussing their problems. And it's usually sleep related. If you have lack of sleep or bad sleep habits, diabetes, high blood pressure, all the different things that I mentioned before when it comes to erectile function also can affect sex drive. But as I said, especially in the case of testosterone replacement, I see it a lot, especially in older men, not men that are in the younger, under 35. I see that they have high expectations for both increasing their libido and their erectile function. That's the number one disappointment sometimes that they get. Sometimes they don't feel anything. That's another minority, but yes. And some of them feel better sex drive, not that great of ED resolution. And very few of the younger ones have obviously all the benefits. So this is something we deal with in the field, the expectations to have testosterone especially do both. So a lot of men in the field, a lot of accounts that you guys deal with, the doctors are prescribing testosterone plus a low dose PDE5 inhibitor daily to synergize, do actually not only the libido side of the process, but also the erectile function side. And libido is very hard to talk about because libido is cyclic. All of us, healthy or not, young or old, we go through cycles. Nature goes through cycles. Women, men go through cycles. So some people sometimes get confused. They expect to have libido, great libido all the time. Well, that's another, maybe when you're young, maybe if you're under 25, I remember those days, but those days soon leave and you get really disappointed. But the lack of acceptance that I see out there is horrible. I mean, most of the guys on Excel Mail are over 35. There are 30,000 of them, and they really expect to be high performers, not only at work, but in the bedroom constantly. And that really, they ignore the fact that we go through cycles. There are people that tend to be light sensitive. When wintertime, they feel like not having much sex, and summer comes. It is cyclic, and nobody can really explain. It's a nature thing. I mean, I'm sure we have reasons, organic issues, why that happens, but libido is cyclic, and it has nothing sometimes to do with anything but the fact that it's part of nature. So erectile dysfunction became hotter in the past since the 90s. But before then, there was very little to give a man. When I was your age, there was nothing. I'm 60. I remember the days. there was no Viagra, there was no Trimix, there was no anything. And especially if you went out and drank a lot of alcohol, and and end up, and then you knew it was going to be probably some trouble. And there was nothing, no pre-treatment. I remind all the younger people now, younger men, it's like, don't complain. This is our amazing world right now. We have a lot of ways to prepare and pre-treat and be ready. I mean, and thank God. I mean, the world has changed. So anyways, in the 1930s, this Dr. Brinkley started experimenting using testicles from goats to implant them to treat impotence. The effect was a placebo effect. From what I hear, there was obviously no. Some men swore by it, but it was really placebo effect. In 1948, Master and Johnson. I don't know if you've ever seen or heard about this couple, a married couple of researchers, wrote a book called Sexual Behavior in the Human Male. And then they wrote another one, Sexual Behavior in the human female. And that really, for the first time, brought to the world discussions about this topic, which was taboo for thousands of years, as you well know. So in the 70s, it was general belief that the majority of erectile dysfunction was psychological in nature. And obviously, that was the focus, therapy and sex therapy. Back then was only the main treatment was penile vacuum pumps, which basically I'll show a picture. That's about all I'm gonna do. So it's really they're falling off grace, although they're still used out there, but it's basically a pump to engorge the penis and then put a constriction ring to block in the blood that is something through it. So that was the only treatment back then, and obviously not very effective. And it could actually be hurtful and damage penile tissue. 1973, this company called American Medical Devices developed the first inflatable implant, penile implant, 1973. So that opened up that business, that side of business. And now there are 2 or 3 companies that actually have several models. And it is the last stage for some men that have tried everything and they're still having issues. And there's some of those, especially older men, prostate cancer survivors, et cetera, that just get tired of trying things. They say, listen, I'm just gonna have an implant, press a little button in my testicles and get saline to fill it up and get an erection. And I'm part of a group that shares a lot online because I'm really interested on how people deal with that. And they seem to be very effective. And some insurance companies are paying for that. In 1980, the injections, the penile injections were the first single agent one was developed. So yeah, so we're starting to see a little bit of that. Although I have to say, I was in the 80s. I never heard of this, even in the 90s. So it was really kind of not a very popular prescription back then. In the early 90s, Yohimbe came out. That's something I tried because it was really hot online back when the internet started in 94, 95. It worked a little bit. It's more of a stimulant from a bark of a tree, but it increases blood pressure a lot. And it really worked probably 30% of the time. So, but I remember those days where Yohimbe was the thing because we didn't have anything else. Okay. In 99, that's when Pfizer introduced Viagra. It was by mistake, by random luck. And they were treating people, men with angina, and they were reporting that they were having erections. It was a side effect of the drug. It was not intended to be for erections. So obviously it made Pfizer millions of dollars to introduce it as billions, and opened up, really, 99, that's when the discussion started happening in the whole world about erections, erectile function, even testosterone. The discussion about testosterone got stronger too. So the industry basically exploded. And obviously the 2000s, and that's one of the reasons we're here with Empower, because the demand is so large, especially for compounded products that are a lot cheaper and have different formulations that are not available out there. 2000, TAP Pharmaceuticals came up with a apomorphine, which is, it was a drug that acted on the brain centers to improve actually sex drive, but it caused so many side effects like fatigue and people got hypotensic and nauseous that it got really removed from the market. But that was the only drug that was designed for centrally stimulating libido through dopamine. And then 99 to 2003, vardenafil and Cialis came out. So it's been a process, but now we're at a point where we have at least 4 PDE5 inhibitors, at least 6 formulations of penile injections, at least 4 models of penile implants, and am I forgetting anything else in the peniles? Yeah, so the menu has definitely increased for men. And men are more willing now to discuss this with their doctors. I do see a shift. So erectile dysfunction was something that most men were ashamed to even discuss. I have to say, doctors don't ask that question. In the testosterone field, obviously they ask it. This is part of the basic workup. But in the general primary care, no, still. And for females, it's even worse. That's not even something that is brought up, even though we know it's part of not only life, but quality of life and health to have a healthy, not only sex drive, and part of keeping a relationship going. Although I have to say I'm 60 and sex is overrated as you get older with a relationship. You're gonna learn. You're all in your 20s, so young. You know, we fall in love, everything is beautiful. We have sex like rabbits at the beginning. And obviously for most of you, you'll have kids. That destroys things for a while because obviously people are tired. And then, you know, companionship eventually when the kids go and everybody, the companionship gets stronger and stronger. Your partner doesn't judge you, you don't judge your partner. And that bond, intimacy grows. And sex may not be as frequent, but you are probably happier. So I do have to say that, because I think sex sometimes can be, especially in our society, very overrated when it comes to, because really it should be about intimacy. Having sex for the sake of it, it leaves everybody empty, really, and you can catch a few diseases too. So I'm not judging, because I'm definitely a pro-sex guy, but as I get older, especially, I realize, you know, intimacy, companionship, and in women, when I see on the female side, that actually turns women more on the intimacy, that connection, than just, you know, wanting to have sex. So just wanted to say that. Don't have a slide on that preachy kind of thing that I just said. You're all young, so I want to make sure that, you know that that's coming and that's okay. You're not gonna, and yeah, you may have testosterone and PDE5 inhibitors to when you do want to have sex, but that urge to perform and to be on all the time, it really diminishes. Thank God. It's a lot of work. It takes a lot of time too. Anyways, so there's also, this product I forgot, which is not really fun, is a suppository, a little tiny pellet that men can put in their urethra called Muse, which didn't sell much, and it's not that effective.
Same
but
ingredients as Trimix. Prostadyl.
Yeah, one a combo of, single dose. So Caverjet is, I'll talk about Caverjet. It's really the only real injectable out there that is pharma grade brand name. Some insurance companies pay for it, so some guys are using it, even though it's not as effective as Trimix. The vacuum constriction device, the implants, and sex therapy. Sex therapy is something most men or even women don't reach out to. So there are urologists here in town that have a sex therapist in their team because they give somebody testosterone PDE5 inhibitors, and there's still issues there that are related mostly about anxiety, performance anxiety, and all that. So we're going to talk about basics on the PDE5 inhibitors. And as I said, Viagra was discovered as a side effect, basically, of angina study. And the molecules actually looks a lot like GMP, that enzyme I told you about, and it has obviously effect on the PDE5.
What is a PDE5 inhibitor?
Oh, that's for that's you had a little bit of a record, a voiceover. So let me go back to where we were here.
the class of drugs that are now available as an ODT. This is the only medication type that is available in the ODT dosage form at Empower Pharmacy at this time. PDE5 inhibitors are commonly prescribed to treat erectile dysfunction in men. The way they work is by increasing the amount of a compound called cGMP.
Okay. See, he's a much better speaker than me. That's why I have him here as a security blanket in case I forget something. Let's move on. So sorry about the busy table, but actually this is one of my most important tables, and you'll get a copy of the slides. We're actually going to put this video in an internal server. As sad is, I haven't told him, but he's going to help. And also the slide, the PowerPoint, PDF, and all that. So, but this is basically a table that compares Viagra, Levitra, Cialis, and Stendra. The type, obviously, they're all PDE5 inhibitors. The dose, a range for each one, peak time when it works. It takes Viagra like 1 hour. Levitra supposedly a little shorter, but not much. I mean, companies tend to push that, like, oh, mine works a little faster, or you don't need to have an empty stomach. You know, that's another thing. Cialis also can be used at very low doses daily or as needed. Where did that come up? Okay, there you go. So yeah, this is a better table. And the only one that stays longer than 24 hours is Cialis. It stays in your system for at least 36. So it can work. They call it the weekend drug because you take it on Friday, and by Sunday you're still performing. But it has also side effects. All of them have side effects like sinus congestion, heartburn. Cialis has lower back pain that most guys don't know about until they read it online. Spasmic, I have all the side effects. I get all of them, except for vardenafil, Levitra, which I get from ODT from Empower. Everything else. Cialis it's got the most severe side effects, and also it leaves your body. It takes a long time for it to get out of your body. So your side effects are going to last a lot longer. But it is becoming the most popular one because it has a long half-life. And some guys want to be prepared, not on Friday, but also Saturday and Sunday. So and it also has been approved for enlarged prostates, for BPH, benign prostatic hyperplasia, at a lower dose, 10 milligrams a day. So that actually makes it possible for insurance companies to pay once the urologist, justifies it. So that's the only thing about Cialis, that it has an advantage because it has 2 indications, and it also has a longer half-life. But as I said, the sinus congestions, red eyes, flushed face, heartburn. The only one that that doesn't really require an empty stomach is Cialis. Every other drug, if you have a full stomach, not only takes a lot longer to kick in, but the efficacy is lower. So I think I covered everything else. Yeah. And these are just brand name prices. They're expensive. That's all I can say. Even the generic Viagra now, it's a lot more expensive, like almost 5 times or 10 times the price that Empower provides. So cost really is a driving force here. Unfortunately, I have to say, because I've seen it, I know the patient population really well because I've been working with them for 20 years. A lot of them don't know that you can get all these medications through compounding. And a lot of them don't know that the cash price is so low that they can afford it. Because Viagra, as of today, still is $55 a pill. That costs what, $5 here?
$5, yeah.
It's the same thing.
It's not covered by insurance anymore.
And it's not covered by insurance. So, and some men tend to access some of these medications through websites in India, or which the government is from what I hear last week from a press release, they're going to crack down on shipments from other countries. But the price difference is huge. So that's really a driving force. And we still have to educate men. I do constantly. My job really online is not only educating, but really letting men know about, and women. I do have 20% of my audience is female. know about their options as consumers, and also how to talk to the doctors about compounding. So what happens, a lot of doctors are like, I'm not gonna compounding pharmacy, they're not safe, or I don't know, they're not FDA approved, when in fact is we know all these ingredients are FDA approved. So the educational aspect of how do you talk to your doctor about the fact that there are cheaper options. Yes, your insurance, and the fact that insurance doesn't get in the way, because some doctors don't want to deal with insurance anymore. And the fact is that you're going to save a lot of money. It's because I think this is a lot of patient-driven market. This market is not only the doctors getting informed, but the patients are asking and demanding. And that's how I see my role when it comes to trimix, squat mix, PD5 inhibitors, et cetera, and testosterone. The OTT formulations, that's a new thing. I don't know why they're moving. They're moving. You probably put them on a timer. That's a new formulation in Empower. It comes in this, you can see, okay, this little pretty box. I ordered the first one 2 weeks ago. Nicely packed, very thin. They dissolve under the tongue. You don't need to even have water with it. Tastes great. It tastes better than the troches. They basically taste like mint. Why am I moving? This is probably, we have it on a timer on this one, because this is in Jason's. And they can actually be cut out. They have a quad groove there, which is really helpful if people want to do low dose. And they don't melt in transit like troches do, and and artificial dye. So, and also they're cheaper. So I am trying to educate men about this. They don't know. They don't know about this option at all. This is new. Basically launched it yeah, and so it's definitely something we need to raise awareness about. They dissolve faster. They're, like I said, they don't need additional water, less expensive, and there's some PK data that actually shows that peaks are actually higher in ODT products. We have all of them except vanathanil, right? Everything else, we have sildenafil, tadalafil, vardenafil. I know that those have been released.
Sildenafil is any day now.
Okay, so we'll have the four available ones. But this is really, and these are replacing the troches. Troches are definitely not going to. What's going on?
It just crashed.
Okay, so the troches are going to be probably phased out in a few months.
Maybe not. Depends on demand. For PD5, sure. And troches we'll keep for hormones.
Oh yeah, okay, yeah. The flavor is different, so it's a lot better. Okay, all right. Sorry about that, guys. Yeah, there we go. Coming soon, the 250. And as you can tell, the milligram dose is different because the drug requires a certain amount of milligrams. They're all not the same. So, tadalafil, which is Cialis, 25 milligrams. A lot of guys are taking 5 to 10 milligrams, so they can cut it and actually not only save money, but extend the use of the product. The lowest price PD5 products that we have now, and they're actually replacing troches. They're cheaper than troches. Yeah, so that's a good thing. These are cost per dose. I'm going to get into that, but really, I mean, you can go as low as $1.38 per dose. So that's definitely something most patients can afford. Blister packets, 3 sheets per box. It's a very pretty professional packaging. So ODT. It's a dissolving tablet. It's rapidly dissolved, melts away, doesn't have flavor. Unlike the troches, I could deal with them, but it wasn't something I wanted to keep under my tongue for too long. It really got a little bitter. So I'm glad to see this improvement. Contraindications, PD5.
Keep crashing over here.
Okay.
This is the audio. So just keep it like this.
Yeah, PD5 inhibitor contraindications. Who should be not prescribed, or doctors should be very careful about prescribing. Men or women, well, we're going to talk about women too, with very low blood pressure, because they can lower blood pressure. People taking organic nitrates for cardiovascular disease, Organic nitrates are definitely the biggest issue because it can have interactions on blood pressure, lowering blood pressure too much, and people can faint and become hypotensic. Yeah, organic nitrates. If somebody has really big heart problems, they should have a stress test. Although the data on that is iffy about whether or not somebody had a heart attack or two can take Cialis or any of the PDE5 inhibitors. In HIV, we have a drug called Norvir, which is a booster. It increases blood levels of all medications by slowing down the liver metabolism. And basically, Norvir can increase PDE5 blood levels by 20 times. So obviously, the side effects are a lot worse, but people with HIV are told cut the dose by a fourth because of this drug called Norvir in HIV. There are a lot of boosters out there. Norvir is not the only booster. I'm not going to go through this. It's basically what I said before, the compounded PD inhibitors and their cost advantage. Oh, this is copy. Okay, so we're moving on to the injections. How are we doing with time?
11 o'clock.
Okay, well, we wasted like 15 minutes getting technology to work. Yeah, there's Carbojet Edex by Triquadmix. Carbojet is brand name. We don't deal with it. It's monoactive, one ingredient. It's large volume, big needle that comes with the package. I used it once just because I use everything for my book. I wrote a book. By the way, we have 2 books here. And at the end, whoever asks the most interesting question that makes me think, we'll get a book. Okay, only 2. So anyways, I tried a bunch of stuff just because I wanted to come from a place of knowledge, not because I needed them. Yeah, right. But anyways, so yeah, the dosage is different. Dropout rates, yes, some men, it works. All these products, most of them work, I would say, 90% of the time. Some of them work too well, and the erection lasts for more than 3 hours, which could cause issues called priapism. You don't want an erection that lasts that long because blood tends to start coagulating in the penis, and eventually gangrene or infections can happen. So that's why patient education is humongously important. We made a video at DeFi on the injection technique because people were getting prescriptions without being told how to inject. They were just being given a drawing. And so we have on Excel mail, we have a video that I tell everybody, watch the video, read, and we have like a 4-page information pamphlet that they have to read because it is something that works really well, but it can also create problems. And a few people have to go to the emergency room in the middle of the night, and no doctor wants to get a call in the middle of the night because their patient got priapism. So, and we do sell a product that is an antidote, by the way, which I'm kind of surprised that a lot of doctors don't know about. So we'll talk a little bit about that. But pain and priapism, fibrosis, if long-term users can start, depending on the injection site reactions and all that, create fibrosis. What is fibrosis? It's basically a buildup of calcium inside the penis that eventually gets in the way of blood flow. But this is like after 5, 7, 6, 7 years of this product and actually injecting on the same side and not doing the right technique. It's a product that requires a lot of education, okay? And yes, a lot of people are ordering, and I'm sure it's a health seller too. I think PDE5 inhibitors are number 1. The penile injections are.
Trimix, what do you think that is on the list of top prescribed medications?
I just told it yesterday.
Top 10?
It's in the, I would say it's in the top 25.
Top 25,
Yeah, okay.
Yeah.
So a little bit lower.
Yeah, and it's, some, obviously there's still fear about it, and there are other options that men want to try before they get to this. This is what I call not only salvage therapies, meaning we've tried several things, and PDE5 inhibitors may work in 60% of men, 40% of men don't respond. They don't. Or it works, but sometimes they don't work all the way. You cannot predict. And I hear that a lot. So that's one issue. And men want to try this. And some of them get tired of injections, so they eventually go to neurologist for an implant. So as I said, this is not salvage completely, it's pre-salvage therapy, because salvage is obviously a surgery. Okay, so pain in the administration of prolonged erections, hematomas, having a bruise there is not really not fun to have. So we have different formulations. Bimix has 2 components, papaverine and phentolamine. Trimix has 3 components. With prostaglandin is an additional component. Quadmix adds atropine sulfate. So Bimix, they all work. I cannot say we have ever had a study comparing each one. I would say Bimix works really well. Doesn't require all the refrigeration that all the other products require. Some people, men that travel a lot, actually, some doctors prefer prescribing Bimix first. Some doctors jump right into Trimix. Quadmix is not as well known. Sometimes it's used for men that are starting to lose efficacy on Trimix. Definitely, that's for Quadmix. And then there's super trimix, super trimix. I'll show the different ratios there. That some doctors just feel like ordering something called super is probably better. That's my opinion, personal opinion, obviously, because trimix works well in most cases anyways. So sometimes it's a matter of the doctor prescribing habits, or the way they market their services. And probably the salespeople, especially in the field, have also had to deal with, because I've heard the questions, with doctors that want their own formula, their own ratios, because that way they can tell the patient, I'm the only one that has this. So it's a marketing kind of thing, but we don't do customized formulas for them. This is what we have, which is a lot, 6 different formulations. And basically one is a main seller. Obviously, it's a lot of info. I'm not going to go through it, but this is just to tell you that each one has a different ratio and different components. Obviously, the bi is 2, tri is 3 components and all that. And then we also have phenylephrine, which is like Sudafed, but in liquid form, that we sell as an antidote. I unfortunately have seen that most patients don't know about it. I wish they did. In my, I've always wanted to have a kit that came from Empower, and we've discussed that has the trimix and the antidote in the same box, especially for newbies. I call them newbies, the ones that haven't done it before, and how to teach them to do that, because that's a lot easier to treat that at home than having to run to an ER, and it's so embarrassing for most people. I've never happened to me, but I've had friends that have happened to. And it's really a traumatic experience. So that's something that I really think would be nice if there was a way. And this is my suggestion, that when somebody orders a prescription, you call them back, ask them if it's their first time users or not, because there should be an option they should know about. And if they haven't gotten a prescription, they can talk to their doctor. And there's actually a protocol to follow, like they inject every 5 minutes until the erection starts coming down. So yeah, it's and of course Empower has beautiful brochures on each product. But as I said, we have a video, and videos do tell a lot better how to do the whole, especially pre-injection technique, because you do have to massage and make sure the product is well distributed. Because if you don't do that, not only it doesn't work as well, but also you may have localized fibrosis that you don't want to build up with time, okay? And there's, as I said, there's this prior prison treatment that I really think we, as an educator, need to make sure that everybody knows about, because they don't. So what I tell people that don't have a prescription is to get Sudafed, oral Sudafed, the real one, the one that you have to ask the pharmacist, because it's behind the counter. They made it so, what, 7 years ago, because people were using Sudafed to make crystal meth. So it's like an amphetamine. So now they put it behind the counter. It's over the counter, but it's behind the counter, meaning you have to ask the pharmacist, because the Sudafed that is on the counter it's not the same thing. It's not as effective. So I tell people, have some Sudafed, especially in newbies. And if you see yourself in 2.5 hours, 3 hours still having an erection, just chew one of these things. Don't even take it, just chew it. If that doesn't work, then obviously you go to the ER. So I know it sounds really traumatic, but it's a minority of patients. I would say less than 10% have this problem. Actually, some of them complain that it doesn't work as well because obviously you have to start very, very small dose because everybody's different, and that dose may not work. And the thing I tell people is that don't inject again. Let's say you inject a very small dose. Oh, it doesn't work. And then you inject again because, you need to, and you're building up. And actually that's what can throw you over the edge with priapism. Also, I tell people, do not take a PDE5 inhibitor especially Cialis within 3 days of doing this, because that can synergize and create more priapism. So there are many things. This is a highly, I said, out of all the things I do, besides testosterone, when it comes to education, injectables like this require a lot of, but people are using it very successfully. It has saved, I've gotten a lot of love letters, love emails from people saying it saved my marriage. It really is. I wanted to feel like a man again. I tried everything. This is shifted my whole life, and my wife is happy. Everybody. Some men complain that their wives are not that happy because they're tired. I don't want to be bothered so much more, and that's another issue. But yeah, that's the thing about men when they increase their sex drive and erectile function is that sometimes they forget there's another part of the equation that you also have to be careful with. And some men are really afraid of needles, so they use this auto-inject device. I think it's more trouble than it's worth, but some guys on my side, they seem to like it. It basically hides the syringe, but the injection goes through the same way. So it's more of an optics thing. It's another one, auto-inject too. As I said, the penile prosthesis or implants are options. It costs over $15,000. Most people get even Medicare to pay for it. And the vacuum constriction device, the one that, as I said, in the 80s, that was the only thing that we had back then, is this weird device here where you have a little bit of a vacuum pump with a little meter there to make sure you're not extending vacuum too much, because that could actually break tissue in penis. But that was and that's still being used, especially for men that are about to go for a prosthesis. They have to do this for a few weeks to expand their tissue before the implant. So Coverjet and Muse are these other products that are out there, they're brand name, kind of competing, but not really. Coverjet comes in a container. As you can tell, look at that huge syringe. Looks like a horse syringe. And the needle too is big. When I saw that, when I got one of them, it's like, this is like, Trimix you can do with an insulin syringe, 29 gauge, 30 gauge, 5/8, little hair of a needle. This thing has like a 25 gauge, 1 inch or half an inch, and the syringe looks like something you're going to use on an animal. So it's and it's high volume too. So it's pretty scary. But some guys say, hey, I don't want to pay anything out of pocket, even if it's $50 a month. Or actually, it's not. It's like $70, $80 for 5 cc's, which you only need 0.1, 0.12 cc's. How many erections is that in 5 cc's? Whoever can do the math. I mean, one bottle of Trimix lasts a long time, and that's only $70, $80. So, hey, whatever. More power to them. This is the most traumatic one. I think this is I think I've only heard 2 or 3 guys that used to because insurance pay for it, but it's this pellet that has one of the components. And I don't know, I want to skip it because it really gives me like, injections don't give me the creeps, but this definitely does. This is a painful kind of a picture. And the costs are actually high too. The Muse, the Coverjet, all that, when it comes, look at the Trimix, $4, and that's per dose. I think it's actually lower than that, but you can see everything else is a lot more expensive. All right, so we're moving along. So bear with me, we're almost there, okay? I have to say, this is the most difficult part for me. And not because I'm a man, obviously, but it's because the data is all over the place. Still struggling with getting products approved. Even the definition of female sexual dysfunction is more complex. Obviously, with men, we're looking at an erection. It's a mechanic thing, right? We're measuring, you know? In females, obviously, it's different. It's about arousal, orgasmic function, vaginal health and dryness, et cetera, stimulation. So there are many factors. And believe it or not, different studies have defined that sexual function in women differently. So the FDA has had trouble pinpointing one good measurement tools, that gold standard for female sexual dysfunction. But it's getting better because at least we have one product approved that opened the door. It's not a very effective product, but at least it got approved. So I think that discussion about female sexual function is increasing because of that. We needed a product approved. I'm sorry, this is a little busy, but in at least in one reference, 43% of American women suffer from sexual dysfunction, over 15 million or more women. Highest proportions between 18 and 29 young women. Why? Because they're also having more sex too, and they're before the childbearing years. But also older women have, especially postmenopausal women, have a lot of problems. Many women can reach orgasm with the clitoris being stimulated, but only half of the women regularly reach orgasm during intercourse. I saw a Netflix special on this, researchers and women and female activists talking about this, and many women in that special have never had an orgasm. They just didn't even know what it was. And it was basically all related to the male lack of ability, because it really is, about clitoral stimulation. So that, for me, in the whole special, was the main point I got. The fact that males suck at stimulating women. Males suck at making a woman comfortable and connect spiritually and intimacy-wise with women, which is part of this arousal. There are many things that we as men are doing wrong when it comes to, and we tend to be a little selfish, and we tend to reach orgasm quick and not do our job to make sure that's not the case. So we're not the first ones, but the last ones to reach that point. So it's very complex. And I do have to say that women have also been very understanding and polite, because obviously nobody wants to judge about reaching orgasm sometimes when they didn't. So that was also very evident in that series that I saw, the fact that some women are compelled to have to lie just not to hurt their partner's heart, you know, about their performance. So, and a lot of women in that program found orgasmic pleasure by themselves with, you know, toys and all that, because they actually could stimulate their clitoris. So I was fascinated. I thought it was an amazing special. If you can look into Netflix, because it's not only talking to doctors, but ladies that have the activists. They're activists now. And you were telling me how that whole world, you may want to say some of that.
At the NAMS that did the documentary on Netflix.
Yeah, so it's actually not only the fact that we are, as sexual partners, are failing women are not speaking up as much, because obviously there's a male ego. and as I said, sexual performance anxiety it tends to be associated with judgment, and that's an issue. So there are different variables in the female sexual functions: a desire disorder, libido, lack of libido, the arousal disorder, a persistent inability to attain or maintain sufficient sexual excitement, an orgasmic disorder, persistent difficulty, delay, or absence of orgasms after sufficient stimulation, and pain disorder, persistent genital pain associated with sexual intercourse. So there are many factors involved. Sometimes, you know, after, obviously I've been working in this field for a while, and sometimes I wonder that having sex, a good sex, and in great performance for both partners, it's almost a miracle. there's so many variables involved, not only mental, physical, medications, stress, judgment, taboos, that it is almost, it's an amazing thing that when two people can have good sex where both reach orgasm and both are stimulated and happy about it. If you have that in your life, embrace it. Take care of that other person, because it really is not as common as people think. You hear from your friends that everybody's having fun, but sometimes you hear more stories than what they're worth. I'm sorry, I got a little distracted there. But obviously, I'm a gay man, by the way. So, but I did date women very successfully till I was 24. So I know a little bit of that. But I also know as a gay man, I kind of take the female side too. I can explore the fact that I'm a feminist in many ways. So I do think that it's both ways, So anyways, let's not get too into that because it makes some people uncomfortable. Well, you guys are young. You don't have the hang-ups we used to have back in the days. So menopause is obviously an issue there. Vascular disease, high blood pressure, diabetes, pelvic trauma, just like men. Basically, we're humans. We have the same issues when it comes fluctuations in the level of estrogen and testosterone hormones could be a cause of sexual dysfunction. Obviously, a fluctuation occurs monthly and during pregnancy that can affect sex drive. In postmenopausal women, sex drive may be reduced because of estrogen levels decrease. We do have some products and creams that can deal with that. Sex drive may also be reduced in women who have both ovaries removed for obvious reasons, hormonal issues, basically. A reduction of sex drive may result from anxiety, depression, etc., problems in the relationship. Kids, being tired, taking care of kids is a big problem. In my world, I used to do a lot of research. We used to complain a lot about the fact that we don't have enough women in any studies about anything. We used to do HIV research, immune research, all that. Where are the women? There's only 10% women. The world is not 10% women. We're not doing enough to bring women in. Where are women? And after studies were done in the sociological aspects, they found out that women were taking care of people. They didn't have time to go to study. It really wasn't about not wanting to join a study. It was basically their ability, time-wise, to join a study because it's a luxury for a lot of women. And so the studies kept bringing basically childcare, all that stuff, transportation, doing things to minimize. But I think we got the maximum we ever got to was 20%. So that happens too here when it comes to female sexual function. All right, so breast cancer survivors too have a lot of issues. Testosterone for women, and compounding is the only source of testosterone product for women. A company tried to approve a testosterone gel like 10 years ago. Libigel was called. I was very hopeful. I thought, oh, wow. Yeah. But they did not get approved. They didn't meet the endpoint because the endpoint was really based on an endpoint, a definition of sexual harassment that was poorly defined. So the company basically let it go, which is good for the compounding industry because we're the only ones providing this treatment for women, which we have good data. It's not like we don't have data on the fact that it improves sexual libido mostly. And very low doses, obviously, not like men, 20 milligrams subcutaneously. Pellets can also work, and Empower is going to get into pellets January-ish. Combinations not only with testosterone, but estrogen, progesterone, DHEA. We're not only talking about one hormone sometimes that can be provided for women. Side effects, too much testosterone, masculinization, fuzzy peach hair, like peach fuzz hair. Did I get that wrong? Little hair, mustache. What do you call that? Peach fuzz? Peach fuzz hair. Clitoral enlargement, menstrual issues, basically amenorrhea, either too much menstruation or menstruation has actually ceased to happen. So, but those are, the dose is too high. So obviously all the doctors prescribing female testosterone and other creams here are doing so because they're very educated. This is not an easy field to get into. We will have a training session with a physician that does basically female-related sexual health and products.
The sweet spot for women for testosterone that these doctors are targeting is about 10% of a male. So the sweet spot for optimal testosterone for a man is roughly 600 to maybe 1,200 nanograms per deciliter of total testosterone. For a woman, it's somewhere between 60 and 120. And that's the top range. And one thing I'll share with you, which is why a lot of these doctors have been doing this for a long time, know more than what's out there in the data. But most women that I've had the opportunity to screen, being on the clinic side, which is hundreds and hundreds of them, even in their 20s, have very low testosterone. And it's mostly American women. There's not anything official on that, but there's some theories floating around on the fact that a lot of women get on birth control very young in this country. Birth control is like giving a young man anabolic steroids. It'll disrupt their own endocrine system. So that by the time that female is in their sexual peak between, the 20s, mid-20s, their testosterone is extremely low. I'm talking single-digit numbers we see all the time. Giving them a little bit of cream and getting them into that upper range of 60 to 120 changes their entire life. Unfortunately, this hasn't spilled over to the academic realm as of yet. It is now starting to get there. Me and Gabby learned at the last conference, but only pockets of women and doctors know about this.
Okay, so these are basically saying testosterone deficiency symptoms as men: fatigue, lack of sex drive, pain, loss of hair, increased body fat, decline in arousal disorder, depression, etc. Viagra for women. There are actually some references, some studies out there that show that it can be effective. It improves vaginal, clitoral engorgement and lubrication. That's what PDE5 inhibitors do. They actually increase engorgement, not only of the penile tissue, but also the vaginal and clitoral tissue. 84% of success rate in decreasing symptoms of female sexual dysfunction, but it's not approved by the FDA for this purpose, but it can be prescribed through, obviously, compounding. What's the dose for women usually?
It's actually the same as men, 5 to 7 milligrams a day of tadalafil or 25 milligrams of Viagra as needed.
So we're not only, Viagra really is the best known, but tadalafil can also be provided, obviously. Vaginal atrophy, a decrease of 50% of blood flow to the vulva after menopause can be restored by estrogen therapy. Regular intercourse also maintains, when you're having vaginal atrophy, it's very hard to maintain regular intercourse. Other products, there's actually an approved product, a serum, that I don't know how well they're doing cell-wise to improve the atrophy issues and the dryness, and the DHEA. Can you talk about products that we have here that could deal with the vaginal atrophy and dryness too?
Absolutely. In fact, we just brought on a new medical science liaison that you guys will have the opportunity to meet probably in the next month or so. His name is Dr. Michael Critchman, who's an OBGYN and a leading female sexual health doctor. And we have a kickoff meeting next week with Sean and I. We're going to be expanding our making a women's health catalog. That's going to include a lot of vaginal suppositories, including DHEA, even diazepam, which is Valium, a benzodiazepine, some progesterones that can be inserted in a vaginal cream using the Pearl Toppy Click to help with not only vaginal atrophy, but dryness and pain, and then also libido. So we'll have, just like we have a urology catalog and a weight management, we are going to have a women's health catalog in the next 3 months that'll be very comprehensive and address a lot of these issues.
Before I move on, I forgot to mention these two booklets that we have from Clinic Optimizers. This one is about PDE5 inhibitors, which David has a bunch, and this one is about the penile injections. It also has a section on patient education, on a brochure basically to give patients. But
you can grab a copy off my desk, by the way.
Yeah, we're going to try to produce more of these because they were very successful. And doctors love that, especially to give out to their patients too. Very hard to read, so don't concentrate too much on it. There are 3 columns in this table: medications associated with female dysfunction. There's a desire disorder, which I said the actual sexual desire; arousal disorder, which is staying excited, aroused while having sex; and the orgasmic disorder, not reaching orgasm. And these are the medications that may affect each one of those variables. And you have obviously amphetamines, you have antihistamines affecting arousal, You have statins and blood pressure medications affecting desire. You have anti-androgens or hormonal contraceptives, like you were saying, affecting desire. And I haven't seen the data on testosterone, but that's very interesting what you said. Tamoxifen, which is for breast cancer, affecting not only desire, but arousal. Contraceptives, even ultra low potency, affect both too. Psychotropics like antidepressants and benzodiazepine, anxiety medications, all of them affect, most of them affect sexual desire and arousal and orgasmic issues. Like in men also experience a lot of lack of orgasms. Aromatase inhibitors, chemo, obviously, and histamine, HA2 blockers, like for heartburn or even allergies can affect desire. So, as I said, that's why I said before, it's actually a miracle sometimes as we get, especially as we get older, because as we get older, men or women tend to take more medications for different reasons, okay? So the treatment for sexual disorder in women, and this was a really good reference I found, really good review. As I said, there are some antidepressants treatments of sexual dysfunction. Wellbutrin has been shown to be good antidepressant because it doesn't cause sexual dysfunction, not in men or women. It's very stimulating, so sometimes some people don't like taking it because of that. Viagra and Cialis can benefit women with sexual dysfunction induced by SSRI or antidepressants in general. Female genital sexual pain disorders are complex, and they need basically a lot of psychological support too. Group cognitive therapy is also another thing that has been tried. Mindfulness-based interventions. Direct masturbation is recommended for lifelong anorgasmia. Anorgasmia is basically lack of orgasmic, reaching an orgasm. And as I said before in that special, I realized that a lot of, and these were young women too, were only able to reach orgasm by masturbation. Local vaginal estrogen therapy is recommended and preferred over systemic or oral estrogen for the treatment of urinary syndrome of menopause and related, basically painful sex. It's called dyspareunia. Vaginal dryness is a primary concern. Osphena is this drug that is also prescribed for painful sex, or what we call dyspareunia. Transdermal testosterone with or without estrogen therapy has been shown to be effective in the short term for low sexual desire. This is the only drug approved. It was approved in 2015 for libido in women. It had been declined once or twice before. A small company bought it, and a lot of women activists got involved. So it got approved eventually, which I was surprised, because it only really increased sexual intercourse by 10% in treated patients. And the side effects were, like dizziness. You cannot have alcohol with this drug, which really rules out a good date, really. Most of us have at least a glass of wine to relax. And fatigue and nausea is a side effect. And Addy, so the company has this top things to know. So basically it's all related to the side effects. What works in a very small subset of women, Addy may cause sudden prolonged unconsciousness. Alcohol should be avoided when taking Addy. Hormonal contraceptives may interfere with Addy, actually increase the blood levels of the drug and cause more side effects. Addy may interfere with a lot of other drugs too. So this was made by the company because the FDA made them do it. So it's not, as you can tell, it's not a very fun drug to, it's not the drug that is going to solve this problem, but at least it opened the market. It opened the market for, once one drug is approved, companies say, let's go for that. Let's go for that indication, because now there is obviously one really ineffective drug that got approved, so that gives hope to other companies to look into. So there are other companies looking into different options. You may want to bring that up, the PT 141.
Yeah, absolutely. There's a lot of drugs in development. One, as we know, there's doctors are starting to embrace androgens and testosterone for women, which again is a compounded option, not available commercially. But now you have several companies that are looking at different peptides. You guys are familiar with peptides in the form of Simorlin and some of the GHRPs and HCG that we make. There's all kinds of different peptides that do different things in the body. One of them is called bromolamotide, PT141, which actually is an analog of a hormone that you have in your body that determines skin color, melanotan or melanin. So people take that peptide, black market source to get tanner. A byproduct of that drug actually is PT141, which causes not just mechanical performance function in men and women, so blood flow to the penis, clitoris, and vagina, but also libido enhancement. And it works very, very well. And it's been on the black market for a long time, and other countries have used it. So I know several people have tried it over many years, and works very well. Now you have a pharma company in the U.S. who's about to, I think they're making it to phase 3.
Phase 3, yeah.
So they're about to bring it to the market as a new drug. Sean has actually found a source for the raw material, so it's something that we're looking to compound for urologists in the female market as well. Of course, we'll make it different than what the commercial manufacturing companies come out with, and that's going to be a blockbuster drug for women's sexual function and men as well.
There's some side effects too, but
There is
it has like flushing and
a little bit of nausea the first time you take it for about 10 minutes, but nothing too bad.
And you know why I don't want to talk about this product? Because I really don't have any data. But I just found out this morning that there are 5 different formulations of the screen cream. So I'm going to let Jason take over this one. This is one that's a little more complex because it has 5 components, or depending, 4 or 3, depending on the formulation.
So most compounding pharmacies make some form of this. It could be known as libido cream, female sexual cream, screen cream is another common name in the industry, but basically it's a combination of several ingredients that provide some physiological and some psychological enhancement in female sexual function. So some of the ingredients you guys recognize, sildenafil, which is Viagra. What does Viagra do? Viagra blocks the breakdown of nitric oxide, or CGMP. Well, the same thing works for female tissue, whether it's the clitoris or the vaginal lining fills with blood, and part of that blood flow has to do with their sexual function and the success of their sexual function. So things like L-arginine, sildenafil, those enhance nitric oxide, CGMP, bring more blood flow. Some of the other ingredients in there help with sensation, which is another important aspect. And then probably one of the most important ingredients would be the testosterone. It's vaginally applied. There's receptor sites in the vagina, just like there is in the penis, directly for testosterone to inhibit some action on increasing libido and function. Then, of course, some of that will get systemically and go to the brain, where the other receptor sites are located that are going to increase not only that drive, but that desire to have sex and that response to sexual stimulation. So screen cream is very, very popular in these niche areas where progressive doctors and patients have discovered it, because again, there's nothing like this commercially. It's only available at compounding pharmacies, but it does work very well. And the reason I know this is I've worked at, with several compounding pharmacies over the last decade, and I've worked with several clinics that use it. I've talked to many, many women, or the husbands of the women that are using it, and it does work very well if it's applied, at the correct dose, or they apply enough of it. So, and this is a perfect example of a compounded product, something that you can't get commercially, that's completely customized. You can go to 10 different compounding pharmacies and probably have 10 different variations of this formula, different ingredients. It's very prescriber/consumer driven, which if you recognize in our other fields that we've done classes on, that's a reoccurring theme, that a lot of these products come from the doctors and even the patients that do their own research and get the doctors to prescribe these things. So it's a very interesting product. And I don't think here at Empower, we've maximized the opportunity, because we went to the menopause conference that I sent you guys an email on, and also the other pharmacy I worked at, they utilize a lot of this. There's a lot of women on this. So being that we came from kind of a men's health urology background as a company, and we're just evolving into the wellness female medicine market in the last couple of years, I think there's a ton of opportunity here, especially after going to the menopause conference and seeing how progressive even institutional OBGYNs are prescribing things like this and testosterone for women. So there's a whole new market for us to open up.
I've heard this question before, and I really don't know how to answer it. I'm sure pharmacists would know, but is the product edible?
Edible?
Yeah.
No, it's a topical cream. And the doses in there are low enough to where, basically, if you apply it topically, you're going to get absorption directly into the receptor sites in the area you apply, in addition to a little bit systemic. But when you eat something orally, it's got to go through the digestive tract and the liver. And a lot of the enzymes in that process will break down and negate most of the ingredients in there. Women do respond to oral PD-5 inhibitors. They respond to oral L-arginine, some of these ingredients orally, but you need a much, much higher dose for it to pass digestion and become systemic, whereas a cream will bypass that.
All right, so I'm done. References, and then we'll go into questions. Before we do, let me make sure that everybody also on the Zoom call unmutes if you want to ask a question, and we'll go from there.
I have another question. Alprostadil is a vasodilator in vitamins, trimins, and quadrants, right? So I've seen that in the UK they use that as a cream base. Is that something that we want to launch in Power?
We've looked at it before. There's very low demand, and the reality is the outcome and the efficacy is predictable because everybody has different absorption rates. Just like with hormone drugs, not everybody responds to it. So you're not going to get a guaranteed outcome with doing a topical alprostadil on the penis, whereas an injection, you're going to always get the outcome.
Yeah, that's a marketing ploy too. If you Google Trimix, you're going to see Trimix gel.
Yeah.
Which the company even sent me a sample because they wanted me to promote it. Didn't work at all. That doesn't get absorbed through the skin. So otherwise we'll be selling a lot of that because you can avoid an injection, right? So much so Muse is a drug, and it has to be inserted in a pellet. So for me, it's maybe there's more of a placebo effect because it really does not absorb through the skin. So all that trimix gel stuff, and people are buying that. Obviously, they buy only once. Think about it. When something doesn't work, especially when it comes to erections, you only buy it once. But a lot of people buying it once can make a lot of money to a scam artist. That's why I say. More questions? It's a hot subject. I mean, we threw a lot of stuff at you guys. Anybody? Let me see. Anybody from the online world? Asking any questions, make sure everybody's, let me look at the participants. Everybody's muted. Adam, Danielle, Jessica, anybody? Everybody's muted.
Nelson?
They're all satisfied with everything we talked about. We're so good. Nobody has questions. Everything is.
Hey, Nelson, can you hear me?
Somebody, Adam.
Hey.
All right.
Quick question.
Do you have any questions? Anybody or any comments?
I do. On Scream Cream, you understand that there's now 5 different formulations. Is there any data or maybe just something that's anecdotal?
Because I have, hold on. I blocked the sound. Adam, try that again because of Jason's recording. Hello?
All right, here we go.
Sorry about that. I had you mute. Yeah, go ahead.
That's all right. On the great news, by the way, that there's 5 different now configurations on the Scream Cream. Just my question is on one of the configurations without testosterone, is there anything that maybe is published or maybe just more anecdotal that, if that product without the testosterone, is that going to, outside of maybe not increase sexual desire, are there any other aspects of not having testosterone in that Scream Cream that is not desired or would make it not the best configuration to prescribe?
No, you hit it right on the head. Without the testosterone is the only ingredient that's going to probably increase drive and libido and the desire. Everything else is more mechanical as far as blood flow, sensation, lubrication, which are all very important aspects to female sexual function. Most other compounding pharmacies I've ever worked with or worked with clinics I prescribe from actually don't include testosterone in their libido cream and still had great reported outcomes. So the testosterone could be more icing on the cake, but then if you look at the total picture and you look at that last aspect of desire and libido, that's just as important as the other aspects. So of course there's a benefit to that, but not all women have a problem with the desire or the libido. It's usually more or less mechanical. So lubrication, pain, atrophy, things like that the other ingredients in Scream Cream can help with by bringing more blood flow and volume to that area.
Yes, and also, David, if a woman is already on a testosterone cream,
You don't need to.
you don't
That'd
need
be another reason
that would be
you
another
probably
reason
wouldn't
why
want
you don't want it, because there are like five different formulations, compounded ratios of up to 4 to 5 products. I just learned that this morning. I didn't know there were screen cream 1, 2, 3, and 4 and 5 and different ratios. With 2 of them without testosterone and 1 of them without Viagra.
Hey, on the same subject, may I ask another question?
Sure.
So, you know, and maybe you were going to touch on this, but one of the configurations is without the L-arginine, which is an amino acid. Can you talk about, you know, the reason why that is? And then, and I know the answer, but I wanted to know if it was just targeted towards just genital herpes, or, you know, any kind of herpesvirus that patient might have, you know, where they would not want the L-arginine.
So yeah, that's a really good question. Thanks for asking that. So herpes simplex, you know, the more common one that everybody has with the oral breakouts, or genital herpes. If you're in active breakout, you want to avoid L-arginine. So, which is why that version is available without the L-arginine, or you can supplement with lysine, which is a little more complex. And that includes the oral simplex, because if you think about sexual activity, you know, mouths are going everywhere. So you want to, you know, avoid that so you don't potentiate that outbreak. And that's why that, you know, that formula is available.
Any more questions?
Nelson, can you hear me?
Yeah.
Hey, this is Adam. How are you? Thanks. Been a great presentation. Question that I have is, and this is probably maybe geared more towards David as well, but why do we not use prostaglandin in our Bimix?
Well, because Bimix is, prostaglandin can actually cause some pain and irritation at the injection site. And it's sort of like hitting an ant with a sledgehammer. If your ED is at a certain level that might not require that much of a robust response. Plus, it's always good to start with any drug and treatment that you're going to be on long term. It's always good to start low and go slow. So Bimix is the other 2 ingredients, which will help, you know, if you were to break erectile function down by levels, it might help with the first handful of levels of more mild to moderate ED. And it'd be sufficient for that. It would mitigate some of the pain and the injection site irritation from a prostaglandin. And then, of course, you could step it up to trimix or quad mix, which would contain higher amounts of that prostaglandin in different amounts.
Also, the refrigeration requirements.
And refrigeration.
Yeah, because that's probably the most fragile of all the you know, molecules in there. It requires, you know, refrigeration. Bimix works well. I tell guys, especially the ones that travel a lot for work, because they don't want to carry a little cooler. And there are coolers, travel coolers, that are used to carry trimix or HCG also. So that's another reason. But Bimix is, I've actually tried all of them, and Bimix works as well. It's just that I think most doctors know only about trimix and they jump right. I think everybody should try Bimix first, because obviously it's a 2-component. The refrigeration requirements are not as strict. And also, why jump into, you know, like you said, like a jackhammer over a problem that may actually require fewer components? So, yeah. Good question. Keep on coming, or let us know. We will have, as I said, we will have all these available online.
For video, and then
I guess I have one more question.
Sure.
Yeah, so with Bimix being a lyophilized product, I thought all lyophilized products required refrigeration once reconstituted.
Well, there's two different components here. So yes, once reconstituted, it's best to refrigerate it, but with a prostadil or prostaglandins, you're dealing with a stability issue, an environmental stability issue, to where it degrades very fast when it's not kept cool. Whereas Bimix will degrade on a much lower plane than your prostadil. So you're talking about more of a stability thing than you are a dosage form issue.
Yeah, so, you know, even a transatlantic flight, that's about 8 hours. That's, you know, that's the longest. You know, this is basically about traveling, because once you get to land, it is recommended always to put it in the fridge so that, you know, it lasts longer. But I've had Bimix out for 3-4 weeks and still works the same. But yeah, but our recommendation is always, we never tell the patient that it's always refrigeration for all reconstituted products.
once it's reconstituted.
Okay, good. And one more thing, just to point out, I know on the slideshow, the PD5s showed that they were different colors. Just an FYI that they're all white.
Yeah, that's true.
Yeah,
The
colors are just
ODT.
for effect.
The ODT, yeah. Yeah, good point.
Let's keep all the other questions. Oh, go ahead, Tara.
Yeah,
One
just
more.
really quick.
Yep.
I don't know if it was asked, sorry, but antihistamine. So a lot of pediatricians, and are we setting up the younger generation to fail because they put them pump them full of antihistamines, antibiotics, they put them on birth control really young.
Antidepressants,
All
anti-anxiety
of these
medications,
things
sleep
are-
medications.
Yeah, are we putting our kids on all of these things at so young? So it's essentially setting them up for sexual dysfunction at these young age brackets of 18.
We absolutely are. In fact, my generation, I think a lot of the problems you see that you would see historically in an older generation are happening at a much younger age because of that fact. And if you think about it, I mean, looking at it, you know, when I was over at the 5, who sees a lot of patients, they were starting to, these patients were getting younger and younger, no history of anabolic steroid or trauma, anything that, and their hormone levels are lower than my grandfather's, who's 90 years old. But then you look at them and I would say 60, maybe even as high as 80% are on one of those drugs from the table. Antidepressant, Adderall, you know, all these different things that doctors are prescribing, or they're taking recreationally. Alcohol, if they're not doing any prescription drug, they're drinking. And all those things will not only lower libido and erectile and vaginal function, but also testosterone, which leads to all the above as well.
And we're sleeping less because of the
Higher stress lifestyle.
Oh, the electronics in bed. Almost everybody's carrying their phone to bed and exposing themselves with that bright light that has been shown to decrease. Even when you go to sleep, you have a more shallow sleep quality. And a lot of the hormones are regenerated through sleep cycle. I really think that's the main problem that we're having. That and obesity, we're all getting heavier. And all the data shows that the heavier you are, the more problems you have sexually and with hormones. So I think it's a lifestyle problem, but we're also the electronics and that has changed, especially you guys. You're all young and you basically grew up with these things. Be very careful. Try to put them away at 10 p.m. and don't look at them. And that's the best advice I can give you. So I was bad with that, and the data is so strong now. They've actually done sleep studies on younger populations that are sleep deprived, and when they think they're sleeping, they're not really reaching REM sleep, which is really key to regenerating all hormones. So anyways, my little suggestion.
We'll go ahead and keep all of the questions for email. You're welcome to email me or Nelson, or you can email Gabby and then she'll get with us, whatever is easier for you. But I always welcome questions. And the reason I also like email is then it creates a dialogue that you can look at, and then we can also share it with others as well. We'll get these videos out to you. So we've done an IV, we've got a testosterone, now we've got a sexual dysfunction video. So you guys will get these videos, they'll be available. We're also going to transcribe them. And then some of them we'll make into little booklets. So that way you have something to maybe give the doctors and use amongst yourselves to train. So we'll have opportunity to revisit some of this as well.
I hope this was useful. Definitely practical, very practical information, right? That you can actually apply to your own life. So thank you so much for coming.
Thank you.
Thank you, Nelson.
Bye, everybody.
Bye. Thank you so much.
I'm glad you were here.